Now the first speaker, now to be serious and more into academics, will be Professor Sauter.
Thank you, Andreas. I cannot be more grateful to Professor Rogler. He saved I am a gastroenterologist, saved my ass. And Larry Egan, Professor Egan from Ireland, he, on very, very short notice, had to cancel because of a family issue. And then I was desperately looking for not a replacement, for someone even better. And I found Gerhard. Gerhard is an amazing IBD specialist, or a star in the IBD field. He was in Germany, Ulm and Augsburg. He not only is a gastroenterologist, he's also has a PhD in philosophy, you know. So he's a little bit more, and he's not only a clinician. He was in San Diego, UCSD, did science. So he's one of the last true physician scientists, and I'm very, very grateful that you came here. Thank you. So now it's a very short intro, just one slide, because we have a problem in IBD because we're not good enough. Now, I present in a nutshell, one case is a real case, and it happened actually this week. I mean, the last thing. It's a lady, 41 years old, long history of ulcerative colitis, treated with the usual suspects. Then it was actually, it's amazing, this disease. It was quiet for 10 years, even more. All of a sudden, it accelerated. We couldn't get it back. And then I started her on the first non-traditional therapy was with a S1P inhibitor, ozanimod, because she also has multiple sclerosis. That two birds with one stone, that would be great. Now, it worked, but it didn't work. Then she has small kids, and it's amazing how many infectious gastroenteritis you can have in a year. So we had to stop it. Then we changed to an IL-23, 12-23 inhibitor. It worked, but then it didn't work so well. Finally, we changed to an integrin inhibitor, vedolizumab. It worked until 3 weeks ago. But see, what I do sometimes, I fly under the radar. She had still at home in her pocket a few ustekinumabs. So then I had actually combination therapy for 3 months under the radar. She was doing well. Now it is tapering out, and now she's not doing well anymore. And that's your talk now. So what to do, and so on. Gerhard, please.
Dear colleagues, it's my great pleasure to be here this morning. I really would like to thank for the invitation. Now, I have the task to talk about combine or not to combine, and as those are my disclosures, you may imagine that I had contact to several companies, and several combinations are possible. But the question is, why combine at all? I mean, we just saw a patient, and the problem is that we have a really sort of therapeutic ceiling in drug development. So what we see here, and Bernhard showed you a case of ulcerative colitis, and what we see here is the remission rates in this ulcerative colitis patients. So in the old trials, on the Act 1 and 2 trials with infliximab, we had like 33 or 38% of remission. But with the new drugs, this seems to be the ceiling. We don't have more patients in remission when we have just a monotherapy. And when we subtract the placebo response, which is on the right side in this graph, it gets even less. So we have around 25% of patients that go into remission. That's the problem with all the new drugs. And when we look into Crohn's disease, it's absolutely the same. So here are the data from, for example, the CALM study, where we look into endoscopic remission, and you see that here we have different definitions of endoscopic remission. Is there a point? No. Okay, but on the left side, you see that endoscopic remission in all segments or complete endoscopic remission. I don't understand that difference is completely, because what you want to achieve is always complete endoscopic remission, not endoscopic remission at one side and not at the other. But what we see is also that this is only achieved in like 20% of the patients. And when we then look into the number of patients in the different studies, the filled bars are always remission, and the more light bars are a response. We see that we have response in up to 50% of the patients, but usually remission can only be achieved in a small proportion of patients. This is during induction. And when we look into maintenance, we see the same. So what happened here in this patient case, that there was a lot of loss of response, is absolutely what we experience in our daily life, that we have patients that lose response during this clinical remission phase over 1 year. Now, what I think has been emphasized by many companies in recent years, and I'm a little bit critical about it, is this treat-to-target approach. And we always should be aware what the target is. And the target can be too sharp or too ambitious, because when we look into what happened now in diabetes, we saw that mortality overall increased when we decreased the glucose levels too much. And this is what I think is now also seen in IBD. So this is the recently published Stardust study. You see April 2022, and there was a treat-to-target group with really a intensive treatment and a standard of care group. And what you see with respect to endoscopic remission or mucosal healing, the treat-to-target did definitely not better as compared to the standard of care group. And the same is true for this study that has been recently published also this year, where the Strident study, where an intensive adalimumab plus thiopurine treatment was used to improve patients with endoscopic, with strictures or inflammatory strictures. And again, the standard treatment group did not worse for most of the outcomes as compared to the treat-to-target. So treat-to-targets, it's not something we should combine for, because it's not better than standard of care, which is great because that means our standard of care is not so bad. When we talk about combination, I know it's always my topic. I don't want to miss this. The forgotten combination, the combination of rectal and oral 5-ASA in ulcerative colitis. People are now already joking because I present that all the time, but you see, oral, 30% of response, rectal 60%, combination 90%. And we don't do that. And it's very clear from meta-analysis, this is one of them. It's very obvious, but when we look into the Swiss situation data from the Swiss IBD cohort study, we see that in left-sided colitis, we have a combination in 10% of our patients. This is reality in Switzerland. So the most obvious and the best established combination is done in 10% of our. Why talk about biologic combination if we are not able to combine oral and rectal 5-ASA? Anyway, we are not alone. We are not alone. This is Brigham's and Women's Hospital, Harvard Medical School. Look into no topical 5-ASA therapy, the second line, 75% of patients. So we are not worse than Harvard. That's the good thing about it. Anyway, the classical combination in IBD. What is the classical combination? It's anti-TNF together with thiopurines. And this, of course, was the SONIC study. And what you see here is monotherapy with thiopurines, 30% in corticosteroid-free clinical remission, infliximab monotherapy 44%, and the combination was 56.8%, and there were colleagues that said, you need to combine. The term was combine or crime, which I think is not a good rhyme, but anyway. What we have to keep in mind is that still in the SONIC trial, we had like 43% with no effect. We had 45% of patients with sufficient therapy with infliximab alone, and the number needed to harm of this therapy is 5. And the benefit is 11%, so the number needed to treat is around 10. So for this additional effect of combination, we have an NNT of 10. The NNT of 5-ASA after surgery in Crohn's disease is 11. And it's always said, don't do it because it's a bad efficacy, right? What is the difference between 10 and 11? 10%. Anyway. So this is the very famous combination therapy, and there have been other combinations for infliximab, for adalimumab, for golimumab, for certolizumab. For most of them, the impact is not known, so the best data are there for infliximab combination with thiopurines. For adalimumab, the combination value is small, and questionable. And for all others, we don't have good data that the combination really has any impact. Now, there are some other published combination therapies, which, of course, have also their impact on patients, but also on the costs of this therapy, I would say. One of the side effects, indeed. So in rheumatology, we have several combinations. They also have, of course, additional drugs that we don't have, like rituximab and abatacept. So natalizumab in multiple sclerosis, there are several combinations possible. And in dermatology and in rheumatology, those combinations are frequently used, for example, with rituximab. So really combination therapies of biologics that have side effects. And I also want to show you one of our patients, a lady that was once responsible for the room where drunk people needed to stay overnight, that the police had taken in custody. She has an ulcerative colitis diagnosed at 2002. The last flare was then in April 2017. She had joint involvement in the CMV colitis, and she was treated with infliximab from 2008 until 2015. And she was really in good remission, but she wanted to stop therapy because she was tired of therapy, and she was in good remission. But then, after a very short post-therapy, we had to restart the infliximab therapy because she had a flare again, and she had an insufficient response. She didn't respond as well as she did initially. So we started the therapy with Entyvio, with vedolizumab, and she had a partial response. So we intensified the therapy to every 4 weeks, but it was not sufficient. You see the endoscopies, she still had moderate inflammation with small ulcerations, and obviously she had symptoms. So what we decided then was she had a partial response to infliximab, and she had a partial response to vedolizumab. So we decided to ask the insurances to support this combination. And what you nicely see here on the calprotectin values, she came from around 2,000, 1,859, and she ended up then at less than 30, so no measurable calprotectin. So the combination of vedolizumab and infliximab for that patient, and both were scheduled every 8 weeks. So the overall costs were even lower as compared to infliximab every 4 weeks or vedolizumab every 4 weeks, right? So this was a cost-saving combination therapy in this patient. Now, there are some case series published, like this one, combination of anti-TNF and vedolizumab in the treatment of IBD. Like here we have a mixture of ulcerative colitis and Crohn's disease patients with really activity. And what you could see also in this case series is that with respect to partial Mayo score or Harvey-Bradshaw index, there was a response on this combination therapy of anti-TNF and vedolizumab in those patients. But it's a case series, and we all know the limitation of those case series. So what about other combinations? Combinations that might be more done perhaps in Japan, because there is still leukocyte apheresis available. We cannot do it anymore here in Switzerland because the insurance won't pay for it. So here are like a number of patients that have a combination of leukocyte apheresis and vedolizumab. And obviously there's also quite good response when you see that the CRP dropped from 5 to 0.5. Also in severe colitis, there are case series here, one of 9 patients with Crohn's disease and 11 patients with ulcerative colitis. And it's severe Crohn's colitis or severe ulcerative colitis, and they were started on cyclosporine IV and vedolizumab. And what we see obviously is also with respect to here the HBI score, that there was a significant decrease on this combination, and we also see that at around half of the patients came into clinical remission and also steroid-free remission. So this is another chance of combining 2 immunosuppressives, vedolizumab, cyclosporine, in severe colon inflammation. Now, there are some data that try to do or some authors that try to do meta-analysis on those limited data case series. And what we see here is the study types. So there's one multicentric retrospective study. The others mainly are, or three multicentric retrospective studies, two unicentric retrospective studies. And so the number of patients you see is like 50 or 40, 22. This is the evidence we have on this biological combination therapy. And when we then look into those limited data, we have anti-TNF and vedolizumab, and where we see here the clinical response, ustekinumab and vedolizumab, it goes up to 80% with response, but then when we look into the data for clinical remission, they at least seem to be not perfect, like 57% again. And when you remember what we saw for clinical remission in the monotherapy, this was also close to that. And this means that, of course, we have only the very, very complicated patients that go into those trials. There was also another retrospective study, the COMBIO study, and you see how many different combinations they used. And there was a persistence of about 80% on those combinations. But the question always is, what do we learn when we just put all those combinations into one analysis, one pot of data, anti-TNF plus vedo, and then vedo plus ustekinumab, anti-TNF plus ustekinumab? I don't think we learn a lot. It just means you can combine and patients tolerate it. So they included like 143 patients and even other diseases like spondyloarthritis. And the persistence rate was, after 104 weeks, after 2 years, was 64%. So there are data indicating that we could combine and we could have some benefit for the patients, but the data are limited. And here, another summary of those studies that have been published. CS means case series retrospective studies, and one randomized controlled trial on infliximab and natalizumab by Bruce Sands, a combination we wouldn't use anymore because natalizumab is no longer indicated for ulcerative colitis and not for Crohn's disease. Now there's one really trial with excellent quality that has been initiated recently, and this is the Vega trial. And it's a combination of an anti-TNF and an anti-IL-23 antibody, anti-P19. And why is this the case? Because they're really good data that the immune system either tries to maintain inflammation via TNF or via IL-23. And Markus Neurath has presented good basic research data that really indicate that when you inhibit one pathway, that the immune cells really try to bypass this pathway with the other one. So it makes really sense from basic research to inhibit those pathways at the same time. And so they, in this study, golimumab and guselkumab are used, guselkumab anti-P19, golimumab as an anti-TNF. And patients either receive golimumab monotherapy for induction or guselkumab or the combo. Unfortunately, the Janssen decided to switch all patients on combo therapy after 12 weeks to the P19 monotherapy. And this is the outcome. So we have a decrease from baseline, so a response in 83% of the patients, and that's 10% more as with the anti-P19 alone. And when we look into data like clinical remission, we see a clear benefit because it's in this patient group, we had like 22% max of clinical remission, and we have like almost 15% more with the combination. So that's quite good. That's almost a doubling of clinical remission with the combination therapy. And there have been new data presented at UEGW that again indicate that at week 38, but you see that the difference between the monotherapy and the combination therapy decreases. And this is also true for clinical remission according to the modified Mayo score. You also see a doubling during the induction phase of efficacy with the combination therapy, but this little bit disappears after week 38. And why is this the case? Those are also brand new data from UEGW. So what you see at week 12, there's a clear cut benefit of the combination therapy. But when you then switch to the monotherapy with P19 antibody at the end of the evaluation period at week 38, the effect of the combination is washed out. So the monotherapy is not as effective after the induction with the combination as the combination alone, and that probably means that we need to combine also for maintenance and not just for induction. Because also during maintenance, the immune system has a chance to escape through the other path. So that's the problem. What are the risks? I think I should shortly mention the risks. We see clearly here with respect to COVID vaccination that when we combine infliximab plus thiopurine, we have tenfold less efficacy. So this is a logarithmic scale measuring the antibody response. So this drop means that we have a tenfold less efficacy of vaccination in the combination. That's one aspect at the moment. But of course, it's all about managing risks. When we know that, we can vaccinate patients on combination once more. But we also should keep in mind that when we have combination therapies, we have a higher risk of infections. We can push patients into sort of an acquired immunodeficiency. When we do too much, for example, with steroids or with thiopurines, it's well established that there's higher risk of infections, especially in the older population, a higher risk of morbidity and mortality in those patients. The immunosuppressives we add increase the risk for opportunistic infections 3.9-fold. And when we have 2 or 3 agents, when we have additional steroids, the risk is 14.5-folds. And especially the risk of vaccine-preventable infections is increased, so we could also use vaccines to prevent this. But this is a nice paper from gastroenterologists just 4 years ago, which shows thiopurine monotherapy. Just look at the people, the blue people here for opportunistic infections, the symbols, the anti-TNF monotherapy, and what happens in combination. So it's an over-additive effect with respect to opportunistic infections when we combine the two. And this is also shown here. It's highly significant that there is a difference, an odds ratio, 2 or 3 immunosuppressives, 14.5-fold risk of infections as compared to just the monotherapy. And when we combine thiopurines plus infliximab plus steroids, the risk cannot even be calculated anymore. It's and this is also well established in meta-analysis, like 3 years ago by Singh from San Diego, that you have a clearly increased risk of infection about combination therapy. And it's not just about viral or bacterial infections. We also see fungal infections that play a role. So the risk of parasitic and fungal infections is hard to quantify, but there are case reports clearly showing that the number increases with combination therapy. So, talking 30 minutes on a lack of data is quite a challenge. There are only few published combination studies with a good design, SONIC and success, and therefore essential information is lacking. And also when you think about the SONIC study, the combination had a limited efficacy. The number needed to treat was 10 for one patient benefit. I think best established combination therapy still is oral and rectal 5-ASA. The combination of infliximab with azacitidine has a number needed of 8. I wrote here 10 perhaps. And I think good monitoring tools are necessary to select the patients that benefit. Should do really ultrasound to monitor the effect of monotherapy, and only in those patients where the monotherapy has not sufficient efficacy, we should combine. Automatic combinations are nonsense. And I really mean that. people that are unable to monitor their treatment response should not treat those patients. Combination of vedolizumab and thiopurines appears to have little benefit. TNF inhibitors, vedolizumab, ustekinumab, and other biologics can successfully be combined. We see it from case series, we see it from very early data. We have, by the way, when I prepared the talk last week, I found that we have more meta-analysis on combination therapy than true studies, which also is interesting. In acute severe colitis, combination of calcineurin inhibitors and vedolizumab may be useful. There are quite interesting data on that, and the risk-benefit analysis are mandatory for combination therapies due to the risks we just saw. And I think in the future there will be new combination options. We just see it from the Vega trial. They seem to make sense, but the only problem is we cannot stop the combination then. What we see from the Vega trial clearly is as soon as we stop the combination effect is lost. It's not maintained. So the best way to predict the future is to create it. And so I think it's a challenge for us all to work on those data for combination therapies. Because I'm also afraid that, I mean, Janssen has guselkumab and golimumab, of course, in their portfolio, but they have the two drugs. And I'm afraid that we won't see many of those really good combination trials if we don't do it ourselves. We have to create those data. But at the moment, I think I want to thank you for your attention, and I say, don't try this at home. Now the last slide is, don't try this at home. Don't combine, just to get your own experience with your own combinations. I think this should be done in really good, well-monitored patients in good cohorts that where you can finally use the data at the end. Thank you.